Good morning, all, and welcome to the 22nd webinar of the virtual rheumatology learning experience. 22 of these, and I think there are 2 or 3 left. Just a few housekeeping comments on how attendees can participate. The chat function is to be used for general comments. The raise your hand function should be used if any attendee is having difficulty or an issue with the system. Q&A chat button, or the Q&A rather button, should be used to post questions regarding the lecture content, and everyone can see what you're posting, so please be professional. With that, I'd like to mention that so far the viral series has touched over 50 countries, and there are over 1,900 registrants and an average of about 400 or more attendees per virtual lecture. So congratulations to each and every one who's helped set this up. I'd like to introduce Dr. Rachel Wolfe today, who will be giving the lecture on PJP Prophylaxis and connective tissue diseases. Dr. Wolfe is currently an assistant professor at Wake Forest Baptist Health in Winston-Salem, North Carolina, and will be the program training director for the fellowship there. She earned her undergraduate degree from Duke and returned to Tennessee to complete her medical degree at Cullen College of Medicine. She completed internal medicine, residency, and rheumatology fellowship at the Medical University of South Carolina, and then joined the faculty at Wake Forest in 2015. She's true passion is taking care of patients in the clinic and is a consummate clinician, but has an academic interest that lies in medical education, both graduate and undergraduate, and she has a special attention to medical decision-making. She was recently accepted into the Medical Education Research Fellowship through the National Board of Medical Examiners. And with that, I'd like to introduce Dr. Wolfe, and thank you for giving your time today on this very important topic for rheumatology.
All right. Well, thank you so much. I'm really excited to be here. I'd like to thank the ACR and Dr. Anisha Dua for getting this all set up. I know this has been incredibly beneficial for my fellows, and honestly, I've really enjoyed the talks as well, and I've learned a lot. I have no financial disclosures. And so today we're going to talk about some of the factors that potentially increase the risk of pneumocystis pneumonia, or PCP, in our diseases. We're going to talk about risks and benefits of prophylaxis for PCP, as well as then talk a little bit more about specific strategies in specific diseases. So what is pneumocystis pneumonia? You'll hear me call it PCP. Occasionally I may call it PJP because the name has changed, but it's an opportunistic infection. So if you have a competent immune system, not generally a big deal. If your immune system is not competent, that's when you can get more of a pathologic infection. And although this has been around for many years, it came to light in the 1980s with the HIV epidemic and became an AIDS-defining illness. And in fact, it was the most common opportunistic infection in the HIV population. But with the advent of antiretrovirals and Bactrim prophylaxis, it really became sort of a non-issue. Excuse me. And then subsequently, as more hematologic and solid organ transplants started, the rates of PCP started to climb, and again, they developed guidelines and were able to prophylax with Bactrim, and it really has become less of an issue in that population. So it's not surprising that eventually it would come to us, and I think that that's happened for several reasons. Number one, we use a lot more immunosuppression. We finally have the medicines to use, and we generally use more of it. And then the original studies, retrospective studies that looked back at the incidence of PCP in connective tissue diseases reported really high mortality rates. So they were reporting rates of like 35, in some case series all the way up to 85%. And so I think this piqued people's interest to say, hey, what can we do to prevent this terrible complication? Unfortunately, we don't really have any randomized controlled trials. We don't have set guidelines. And so it often falls to personal experience. And while your personal experience and your what you've seen can be helpful in informing things, right? It's not always the best way to treat the mass public or the patients in general. And so, the next question is, okay, well, if we don't have guidelines, we should just make them. And while that sounds very straightforward, I think that there are a lot of issues in making guidelines. So I know that you all, or imagine you all, much like me, think that our diseases are fairly common, right? My schedule's full of RA and lupus and vasculitis. But actually our diseases are quite rare. So if you take our diseases, which are rare, then you're looking for an even more rare subset, the people who develop PCP, in this small population. And so the absolute numbers end up being very, very low. So you are looking for like a needle in a haystack. However, I think that might actually oversimplify the issue because it implies that all of our diseases are the same, that they are all metaphorically hay, right? And I think that if you think about the pathophysiology, say, of GPA versus rheumatoid arthritis, you can understand that they probably don't have the same pathophysiology, they don't involve the same organs, they don't have the same mechanisms where they cause destruction. And so perhaps having some sort of blanket statement for all of our diseases would not necessarily be the best step forward. So we have rare diseases, our diseases are complex with different pathophysiologies, and then you layer in our medications, right? So we give people things like Cytoxan and rituximab, all the way down to something like Plaquenil. And obviously those medications suppress your immune system and increase your risk of infection. And so how much of that plays into the development of PCP? And then on top of that, you're layering in both our friend and our enemy, prednisone, right? And so we'll talk about the risk of prednisone in PCP as well. But so you have rare diseases, heterogeneity of our diseases, you have lots of different, it depends on how you diagnose PCP. So whether you're using microscopy or whether you're using PCR, can you tell the difference between colonization versus a true infection? And so I think all of these come in to say that, it makes it hard to have a definitive set of guidelines. So if we don't have guidelines, what would be, what are people doing? And so there were two studies, two surveys sent out to rheumatologists that asked this question. One included about 700 respondents, and out of that, about 70% reported that at some point they had prescribed prophylactic antibiotics for PCP. That still leaves 30% that had reported that they had never done that. And it's interesting, although 70% said they had, there was such a wide variety in their practice patterns of when and how they decided to do prophylaxis. In general, the biggest determining factor tended to be the therapeutic regimen, in about 70%, with only about 9% choosing that the diagnosis was the most important factor. And I just want to bring that up here because I want you to remember that as we go through this lecture. The second survey was a little under 300 rheumatologists, and it looked specifically at the use of at the use of cyclophosphamide in lupus patients. So it was just looking at that one disease and that one medication, and they found that only about 50% of rheumatologists prophylaxed their lupus patients while they were on cyclophosphamide. So again, there's a lot of variety in what rheumatologists do. And so the thought is, okay, well, maybe if rheumatologists don't know, infectious disease doctors might know. And so this was actually a survey I did with one of my infectious disease colleagues to basically answer this question is if rheumatologists don't really know exactly what to do our colleagues. And so we sent out a survey to infectious disease doctors. We had about 630 respondents, and there was a wide variety of practice patterns again. Upwards of about 40% actually said that they didn't even make recommendations for prophylaxis in connective tissue diseases. They felt that that was outside their practice scope. But for the ones that did, again, they, much like rheumatologists, felt that the therapeutic regimen tended to be the biggest determinant. When we ask about the specific diseases, it was actually pretty interesting. And so they could select more than one option. That's why the numbers don't all add up to 100. But only about half of them actually recommended PCP prophylaxis for GPA. And I think that in general, right, that's something we would generally consider prophylaxis for. But then if you look towards the bottom of the pyramid with GCA, right, so giant cell, about a third of them recommended prophylaxis. And I think that if I could have you all raise your hands of people who prescribe prophylaxis for GCA, we would find that most of us in this metaphorical virtual room do not do that, if that's appropriate or not. But the point is that there's a really wide variety in what they thought was appropriate for prophylaxis. And interestingly, they had the option to select not sure as well. And that was one of the most frequently chosen options. So even if they did make recommendations, they still were not sure of what to do. So in the first 10 minutes or so, I just told you that we don't have guidelines. We don't have the ability to make guidelines. It would be really difficult. And rheumatologists don't know what to do, and infectious disease doctors don't know what to do. And so I suspect that there's a little bit of confusion, right? Like, okay, Rachel, like you spent all this time telling us what not to do or what we don't have. How is this supposed to help me take care of the patient sitting in front of me in clinic? And these are my two little boys during a photo shoot. I'm not really sure what happened, but I think my littlest expression fits how I feel about PCP prophylaxis. So what are some of the risk factors that do put our patients at risk? And, you know, and before I go there, I do want to say, if you came to this lecture and you leave this lecture with this set plan of like, I'm going to prophylax patients X, Y, and Z always with like set definitive guidelines, then I think you missed the point of this lecture. PCP prophylaxis, because we don't have guidelines, because we don't have tons of data, is going to include some art of medicine, right? And I think as rheumatologists, this is sort of what we flourish in and all these shades of gray. So my goal of this lecture is to give you the tools to be able to make these decisions in your patients on an individual basis. So what are some of the factors that do put our patients at risk? We'll talk about the first three kind of quickly and then talk a little bit more about the immunosuppressive regimens. So CD4 count is an appealing thing to look at, right? It's well documented in the HIV literature that there's a set cutoff. If you're above that cutoff, you don't get prophylaxis. When you hit that number or you're below it, you get prophylaxis. And so it's a very nice, easy way to approach when to prophylax somebody. But the problem with our diseases is that all of our data is from retrospective studies. And so the problem with retrospective studies is that you can only collect the data that's there. And so unfortunately, CD4 counts are not something that we routinely check in practice. So when you go back to look at these cases, those numbers are not there. But if you do pull the data, or you do pull out the patients who have CD4 counts available, and we're talking like numbers 20 to 30 total patients, it does seem that numbers under 200 seem to confer, like that captured all the patients who developed PCP. The problem with this, though, is that it doesn't control for the patients who did not develop PCP, right? So does it turn out that all of our patients have CD4 counts less than 200 and that's not actually a good benchmark? Or is that actually a good benchmark? And so unfortunately, there was no comparison to see what CD4 counts are in our patients who don't develop PCP. Interestingly, I think lymphopenia has a little bit more data and something that we can potentially use a little bit more in clinic. Obviously, they're able to have in all the retrospective studies, because we check CBCs more frequently than we do CD4 counts, there's a lot more data to include in this. But the numbers are still small. So like one of the biggest studies was 44 people. So again, that absolute number that I talked about in the beginning is part of the problem here. And so what they did find is that lymphopenia does seem to confer a risk for PCP. And there was actually a small study that included, I think, 11 patients, and it controlled for the underlying disease, and that risk of lymphopenia persisted. And what's even more interesting is that the risk of infection or the risk of developing PCP is regardless of if the lymphopenia was before treatment or even after treatment. So whether they had that lymphopenia before you ever gave them Cytoxan or whether they develop it on Cytoxan, that risk seems to be persistent. So, right, this sounds like, okay, this is good. Maybe we can use this. What's the magic number? And again, this is sort of where things don't come together like we would hope. And so, interestingly, the studies are very varied or widely varied on that actual number. Some report 200, some report 800, and sort of everywhere in between. So I'm not going to have a specific number to give you, but I think that if somebody is lymphopenic, it should start to make you think about, hey, is this somebody that I need to prophylax for PCP? And then talking about comorbidities. So again, we're limited by our retrospective studies, right? What they do is they go back through their database, they pull all the PCP cases, and they say, hey, of all these patients who develop PCP, what do they have in common? And so the data tends to be very specific to the cohort that they're looking at. Some of the things that seem to pop up in multiple studies are things like underlying lung disease and old age are risk factors for developing PCP. But then again, based in, and depending on what cohort you look at, it could be some noticed increased risk in Asian descent, some in Hispanic descent, some in Caucasian descent. And then you even have things like private medical insurance was found to be an independent risk factor, and the season of fall in Australia was a risk factor as well. And I don't say these because I want you to say like, what season is it? Like, should I prophylax them? Oh, it's the Australian fall. I should give them something, right? It's to point out the fact that we don't know everything that comes into play in the development of PCP. And so we have to be mindful of all of these features when we're making these individualized decisions. But again, old age and underlying lung disease seem to be found in multiple studies. So let's talk about the immunosuppressive regimen. We'll talk first about steroids, a little bit about Cytoxan and rituximab, and then DMARDs as well. So I don't think it's up for debate that the more steroids you give somebody, it decreases their immune system, it increases their risk of all-cause infections, and certainly increases their risk of opportunistic infections. I think that point is not really up for debate. But then it comes down to what actually confers that risk, right? Is it the daily dosing? Is it the cumulative dosing over time? Is it the presence or absence of pulse dosing? And so this has been looked at in several retrospective studies, and with the exception of one that saw some change with pulse dosing, the rest found that it was basically due to the daily dosing schedule. And so if you go with that and say the risk is generally with daily dosing, then the question is, that holy grail question is, what's the magic number, right? At what dosing does somebody's risk for PCP go up? At what risk could you stop prophylaxis, right? And unfortunately, again, there's maybe not the most finite definitive answer there. If you look back at all the series, it's anywhere from about 15 to 40 milligrams. And the hard part is that, for example, there's a retrospective series from Mayo, and they found that 30 milligrams was kind of their magic number, if you will, but they still had, several cases of PCP under that dose. And so that's the hard part is do you go down to where you have no cases of PCP, or do you get where you get the vast majority? And so I think one of the best reviews about this particular issue is done by Park, Curtis, and colleagues, and it was in the Annals of Rheumatic Disease. And it's a very large cohort of connective tissue disease patients, so mostly lupus and dermatomyositis, polymyositis, and then the rest is a mixture. And what they did is they looked back over 10, 11 years, and they looked for incidences of high-dose steroid use. And what they defined as high-dose steroid use was 30 milligrams of prednisone or more, or prednisone equivalent or more, for 4 weeks. And then they looked to see if that patient happened to receive Bactrim prophylaxis. If they did, they went into one arm. If they didn't, they went into the other arm. And so out of those 1,500 incidences, they only had 30 cases of PCP. Interestingly, they found that generally the risk was about were for doses of 15 milligrams or more of prednisone, but that only captured 27 of the 30 cases of PCP. There were 3 cases who had prednisone under 15 milligrams, but those patients had other risk factors such as age, lymphopenia, the use of Cytoxan. So, you know, again, that perhaps the risk is not as easy as is there prednisone or not. And I will just bring this up because I think it's also interesting too. They did a multivariate analysis and found that the initial steroid dose of 60 milligrams or more, when it was up there, the PCP prophylaxis was actually more effective. So again, there's probably something to be said about the daily dosing of the steroid, but where exactly that number falls is just a little unknown. But based on what I've said, I'm probably thinking, okay, about 15 milligrams or more of prednisone for a prolonged period of time, I'm just going to prophylax everybody. That sounds reasonable. However, the question is there something else going more? And this is why it's really important not to just read the abstract of an article, right? Because if you read the abstract of that Park and Curtis, that would kind of be your takeaway point, right? Oh, like prednisone, more than 15 milligrams, they should get PCP prophylaxis. But if you go back and you look at the actual incidence per 100 person years, overall it was 2.37, but if you break it down by disease, for an ANCA vasculitis, the risk, or the incidence, excuse me, was 12 versus lupus that was 2. So clearly there's more than just the prednisone, right? There seems to be a underlying disease component, and maybe in part that's from medications, but maybe there's something else going on. And so I would also have you consider giant cell arteritis, right? So these are a patient population that we give high-dose steroids to, sort of unabashedly give high-dose steroids to, maybe a little less so with tocilizumab, but we put them on high-dose steroids. They're on steroids for a really, really long time. And when you look at the incidence of PCP in this population, it is very, very low. So even though we're giving them the same risk that we give to, say, the ANCA vasculitis, there's something else going on, right? And all I'm trying to do is sort of lay the groundwork that forces you to think about how you're going to approach prophylaxing patients. And I will also just say here, so Parks and Curtis, the same people who did the study earlier, put out a new study recently that looked at medium dose and low dose prednisone and the incidence of PCP. And they defined low as less than 15, and they basically didn't have enough cases to even do any sort of analysis. And when they looked at medium dose steroids, so 15 to 30 milligrams, they found that overall, there didn't seem to be a lot of cases, but the patients who did develop PCP had additional risk factors. So for example, lymphopenia, age, concurrent medication use. So again, although prednisone is certainly a risk, and I don't think that there's any way around it, it doesn't account for everything. So let's talk about our immunosuppressants. So cyclophosphamide is much like prednisone. I think that there's very good data out there that say the higher doses of Cytoxan you give, the more infections you get, the more opportunistic infections you get. I don't think that that's really up for debate. But what's interesting is in GPA, when they look at patients who developed PCP who had GPA, they didn't find that cyclophosphamide use was an independent risk factor. So perhaps, even though it may contribute, it's again not the whole answer. And if you go back to that survey of rheumatologists I mentioned that was looking at cyclophosphamide use in specifically lupus patients, in addition to doing the survey, they actually sent out, they actually did a meta-analysis, and of 76,000 patients who have lupus who are on cyclophosphamide, they only had 121 cases of PCP. So if you think about that, that's a really, really small percentage. And so obviously cyclophosphamide doesn't account for all the development of PCP, right? That rate is much higher in the GPA population, but both of these groups of patients got Cytoxan, so there's something else going on. And then if you follow that up and you think about, okay, when else do we give Cytoxan? Do we ever give Cytoxan in the absence of steroids? Well, it turns out we do when it comes to scleroderma lung disease, right? These people have a rheumatic disease, they have underlying lung disease, and we give them oral Cytoxan, right? And so if you look at some of the scleroderma lung study trials, there's really not a lot of evidence to say that there was a lot of PCP, right? And so I would argue that sort of all of these factors should make you start doubting whether therapeutic regimen can be sort of the main determinant or even the sole determinant of whether or not you prophylax. When we move on to rituximab, again, I think that this shows, I think that the varying rate by disease kind of tells the story. So if you Google or PubMed search rituximab and PCP, all this stuff comes up for chemotherapies and those kinds of things. But when you look at it in our diseases, right, we give rituximab to GPA and there are, in theory, lots of cases of PCP. But we also give rituximab to RA and there are not a lot of cases of PCP. So I think that the risk can't be just as simple as the medication. It's a combination based kind of starting at the underlying disease. And the same is true for the rest of our DMARDs. For the sake of time, I wasn't going to go through all the individual data, but basically any DMARD that's out there, biologic, non-biologic combinations have been implicated. There are case reports of PCP developing. However, there's no causality. So we've talked about some of the factors that are involved in patients developing PCP and our decision to prophylax. And I hope that I've sort of woven the story to make you think about the underlying disease is an important factor in whether or not you prophylax. And so that's what we're going to talk about. But first, I do want to talk about what agents we have to prophylax with, because I think that this is actually going to play a role in determining whether prophylaxis is important or is indicated rather. So we have Bactrim, we have Dapsone, we have atovaquone, and we have pentamidine. Here is a table that kind of gives you the drug, the dosing, side effects, and then the cost of the drug per month. I want to remind you that something like pentamidine is actually inhaled, and so even though it says it's $200 a month, you still have to go to the hospital. There has to be a respiratory therapist. You have to get it. You have to do it there. So there are other costs that increase that risk. Or excuse me, that there are other costs that increase the total amount per month. And then the question begs is not just cost, because I mean, looking wise, Bactrim seems very cost effective, but is any of this actually efficacious? And so we don't have any studies that shows statistical significance in terms of preventing PCP, in part because we just don't have the numbers, and sort of the retrospective nature of this. But if you look at all of the studies, there certainly is evidence to support that it probably is beneficial. So if we go back to that Park and Curtis study I mentioned with the steroids, they had 30 cases out of the 1,500 high-dose steroid incidences. So of those 30 cases, only one was in the prophylaxis arm. And they were prophylaxed with Bactrim. So versus 29 in the control arm. And we'll talk a little bit about rave and rituximab and those kinds of things. And there's pretty good evidence that because there isn't a lot of PCP and mandatory prophylaxis as part of those protocols, that you could argue that Bactrim is probably pretty efficacious in our patient population. There was one small study that looked at the efficacy. And so it was 96 patients who had connective tissue disease getting high-dose steroids, and they were started on Bactrim. And if they couldn't tolerate that, they were switched to atovaquone or pentamidine. And out of the 96 patients, nobody ended up developing PCP. So again, this sounds pretty good. And it sounds that like, okay, maybe atovaquone and pentamidine are not unreasonable options. For some reason, there's just really nothing out there about Dapsone. However, I would throw this out there just sort of as food for thought. So in the HIV population, there are some studies that show that atovaquone is not as efficacious for PCP prophylaxis as Bactrim. And then there was actually one small trial that looked at connective tissue diseases, and they randomized either to Bactrim prophylaxis or pentamidine. And out of the 48, none in the Bactrim arm developed PCP, but 3 out of the 18 in the pentamidine arm ended up developing PCP. So it's just food for thought that even as we move past sort of our first line agent of Bactrim, that we may not really have solid evidence to say that this is particularly efficacious. And I don't think that means you can't use them. I think it just means that it factors into your decision, and perhaps that number needed to treat or number needed to harm needs to be adjusted. So everything we do is about balancing benefit versus harm. And so I'm going to talk mainly about Bactrim because I think that's where we have the most evidence for. So when we talk about the prophylactic benefit that we get from Bactrim, you know, as I said earlier, it's generally seems efficacious in connective tissue diseases. And there is very well documented benefit in HIV and transplant patients. It reduces, so in this Cochrane-like review by Green and colleagues, they found that it reduced mortality by 91%. The number needed to treat in the transplant population was about 15. Which I think is a very good number needed to treat. In an updated review, Cochrane review, it showed that it decreased the number of cases by 85%. So it seems like in other populations, it tends to be pretty efficacious. And so in this review by Green and colleagues, they looked at balancing the number needed to treat versus the number needed to harm. And what they found that is if PCP rate is greater than about 3.5%, then generally prophylaxis is beneficial because it's at that number that the number needed to treat equals the number needed to harm. And so we'll talk a little bit in just a second about the downsides and the number needed to harm. But to put in perspective, so for example, for something like GPA, the number needed to treat is 32 and the number needed to harm is 32. Just as an interesting point, so there was a cost analysis done that showed for Bactrim prophylaxis for PCP in GPA that there was an improvement in quality adjusted life years as well as a significant cost savings. Interestingly, if they transition to any of the other agents, so to pentamidine or atovaquone or dapsone, that benefit was lost. And to put it in perspective, not only in the quality adjusted life years, but cost. And so, you know, they quote that switching to pentamidine prophylaxis increased the cost per quality adjusted life year to $58,000. So again, when we start thinking about using a second line agent for whatever reason, we need to realize that that comes at a cost, and that may play a role in changing those number needed to treat and number needed to harm. I want to talk a little bit about lupus and Bactrim. Oh, I'm sorry, I think my slides are out of order. We'll pop back to that one. Let's talk about a little bit about the harm of Bactrim. So it has a laundry list of side effects. I don't think I need to go over those with you. They're anywhere from diarrhea to Stevens-Johnson. And so those are things to consider, but we also need to consider the interactions with the medications we use. So our go-to medication is often methotrexate, and methotrexate and Bactrim can cause a terrible and very quick pancytopenia. It can happen in as little as 2 doses. I will point out that this is typically with therapeutic doses, not necessarily with the doses that we would use with prophylaxis, but it is something to consider. If methotrexate is the best medication for the patient, are you really willing to take them off the best medication to treat their disease to be able to give them prophylaxis? The adverse event rate is really important to think about as well, right? That's sort of where we get this number needed to harm. And so if you look at sort of connective tissue diseases along with transplant patients, so all non-HIV immunocompromised, Green and colleagues found the adverse event rate to be about 15%, with about 3% being severe, but all were reversible with cessation of therapy. When we look at specifically at connective tissue diseases, again, these are from small retrospective studies, but the rate increases to about 20 to 43%, so a really wide range. And again, those are mostly for therapeutic dosing rather than prophylactic, and we'll talk on the next slide about what happens to that adverse event rate as we go to prophylactic. So I want to talk about lupus and Bactrim in particular. I know Dr. Petrie had mentioned this during one of her talks on this viral lecture series as well. So it's noted that patients with lupus have an increased reaction or risk of reaction to antibiotics in general, and particularly in the sulfa class. So Dr. Petrie, back in 1992, did a study looking at the Hopkins cohort and found that about 31% of patients, lupus patients, had a reaction to sulfa, and actually 21% of those patients subsequently developed worsening of their lupus. Pope and her colleagues then about 10 years later started looking, and they actually said, hey, is this just in lupus or is this in all of our diseases? And so they compared lupus to an inflammatory arthritis cohort, so psoriatic, rheumatoid, and she found that the risk persisted, so that even compared to an inflammatory arthritis group, lupus patients were more likely to have adverse outcomes. She reported that the adverse outcomes in lupus was greater than 50%, and that rash was most common. I will say that this was a survey done. They called up patients and asked them, what antibiotics have you been on? Have you had reactions to them? So there's probably some recall bias in that. But it's important to realize that those first two studies are for therapeutic dosing, not for prophylactic dosing. And so if you look at some articles that look at prophylactic dosing, the adverse event rate does go down. And so in this study, they looked at connective tissue disease patients, and it wasn't just lupus, it was kind of all comers. And they actually, interestingly, compared it to a pulmonary disease cohort. So all of these patients were undergoing PCP prophylaxis, and they looked at the adverse event rate. And connective tissue disease patients, it was 7%, and if you pulled out the lupus patients, it was 11%. But what's really interesting to me is that the pulmonary disease was 2.6% for their adverse event rate. So even though we think of this with lupus, it really may be that a lot of it's something that we have to think about in all of our diseases. I will say that in the studies, and there were a couple other small studies that found similar findings, and out of all of those, there was actually no worsening of the lupus. So it seems like maybe at prophylactic doses, perhaps even though they have adverse event rates, it doesn't flare the lupus as Dr. Petrie found out. And although I feel like I hopefully kind of sold you that perhaps the rate's not as terrible as initially we thought, I think the jury's still out. So that Japanese trial that I spoke of earlier that had 96 patients and they were all started on Bactrim, 43% of them had to switch to either pentamidine or atovaquone. Interestingly, almost everybody who had a reaction to Bactrim also had a reaction to one of those medications. So again, I'm not really sure how much of it is the Bactrim just versus the underlying disease. But I think that plays a role in how we decide when to prophylax and when to not. So we've talked about the CD4 count, lymphopenia, comorbidities, the immunosuppressive regimen, and what we actually have to prophylax. And so it's finally time to get to the underlying disease. And I like I said earlier, I really hope that I've woven this picture for you that it is reasonable to start considering how we would prophylax based on the underlying disease. So if we look at granulomatosis with polyangiitis, I like to start with GPA because I think it has the most robust data. You know, when you look at the incidence based on these retrospective studies, that it's anywhere from 60 to 120 cases per 10,000. Again, these are rather small studies, but of note, they all seem to happen during induction therapy. So based on those numbers, the number needed to treat ends up being about 32. And again, if you take the rate from that review by Green and colleagues, the number needed to harm would be about 32 as well. So, you know, that's probably a fair trade-off. I think that if we look at, since we don't have great data that says, you know, we don't have randomized controlled trials that say, like, specifically looking at PCP prophylaxis, we still can glean some data from some of the larger trials that actually look at treatment of GPA. So some of the early cyclophosphamide trials that were comparing IV cyclophosphamide to oral cyclophosphamide, what they found is that in the first 12 patients that they enrolled, they ended up having like 9 or 10 PCP patients develop PCP. So they actually stopped their study, added PCP prophylaxis to their protocol, and then resumed. And so a total of, out of the entire study, 10 out of the 50 patients ended up having PCP. But once they started prophylaxis, there were no further cases. So, again, that's not direct data, but I think we can see that obviously PCP prophylaxis that made a significant difference in that particular patient population. And I think it's because of studies like that that actually now most GPA trials actually have mandatory prophylaxis. So if we look at Rituximab, they had no cases of PCP out of their 44 patients. What's interesting, even though it's quote unquote mandatory, only 30 patients were actually on prophylaxis. So again, even though we think that there's probably good evidence to say we should prophylax everybody, it may be that as we go along, we can figure out exactly who needs it and who does not. When you look at the RAFE trial, it also had mandatory prophylaxis. And again, everybody started out with Bactrim, and they do have dapsone and pentamidine as secondary options. But the RAVE trial the actual trial itself doesn't report specifically on PCP, but the opportunistic infections were low. When you look at the RAVE extension, which goes into maintenance, PCP prophylaxis was continued during that time as well. And out of the 197, there was only one case of PCP, and they specifically mentioned that that patient was non-compliant with the prophylaxis. Speaking a little more to maintenance therapy, so in the main Ristan trial, which was Imuran versus rituximab for maintenance therapy, they also did prophylaxis and only had one case out of 115 patients. But what's actually very interesting is that they only did it in patients who had a CD4 count less than 250. As I said before, we don't have a specific number. They probably borrowed that in part from some of the trials, for some of the HIV data, as well as some of the initial studies that I talked about earlier. But, honestly, they didn't prophylax everybody, and they still only had one case out of 115. And then I'm just going to throw this out here that there are some small studies that show that perhaps there's a role for Bactrim in the treatment of GPA. Certainly does not replace our immunosuppression, but that adding that in can maybe decrease the risk of relapse, maybe thought to be secondary to decreasing infections or triggers that would cause a flare, perhaps via its folic acid inhibition, which is why it interacts so strongly with methotrexate. So it's always just one more piece to the puzzle. And generally that's therapeutic dosing, not prophylactic dosing. So my general recommendation would be to do Bactrim prophylaxis for GPA. And per sort of EULAR guidelines, I agree with them. I would expand that out to ANCA-associated vasculitis during induction therapy. And, if you look back at MPA cases in the literature, they're just not as frequent. There certainly are lots of cases, but I think that the interest sort of back when all of the initial cohorts were being done was in GPA, and so that's what people focused on. I would also throw out there that, before the advent of ANCAs and things like that, that there might have been some misclassification as well. So I think including their pathophysiology is similar, I think including them all together and this guideline is reasonable. And again, like I said, this is consistent with EULAR guidelines that recommend PCP prophylaxis for induction therapy. And I know that the ACR is actually looking at this as they develop guidelines. It was one of their questions to answer. So you say, okay, Rachel, this sounds great. We'll start prophylaxis. That's the easy question. When do you stop prophylaxis, right? And I think that that's the harder question to answer. And I think that that is a whole separate talk in itself, one that I would not want to give because it is very complicated and very muddy. But I think based on what I have read and, things like that Park study that found that the 15 milligrams seemed to be kind of the major turning point, I would probably say stopping around 15 to 20 milligrams of prednisone is reasonable, but I think that this is where the art of medicine comes in and that you can't just blanket apply statements to our patients because I think you need to have an individualized plan. So if the patient has lymphopenia or if they're old age or, they had terrible lung involvement, then maybe that's a patient that you continue to prophylax. potentially for longer, right? Because remember, in that Park and Curtis study, there were still 3 cases out of the 30 that occurred under 15 milligrams of prednisone. So I really think it's going to take an individualized plan, even if we have some broad overarching recommendations. And I think that, you know, as we talked about, like main wristband and rave extension, like these are maintenance therapies that have prophylaxis. So the question is, should we be prophylaxing for maintenance therapy? And unfortunately, I'm not 100% sure that we really have an answer. You know, I think it's a very reasonable question to ask because we use Rituxan for induction, and now we're using it for maintenance. And so I think it's a reasonable question to ask. But again, I would probably say right now there's just really not enough evidence to sort of say either way. And so generally, it seems like most of the risk is in induction therapy based on the older retrospective studies that I would say I probably wouldn't. But again, if I had a lymphopenic, somebody who had persistent lymphopenia, or they had other risk factors, I would maybe consider doing that. So I think that lupus is really interesting because lupus itself has such a wide range of disease manifestations. We've all had that lupus patient who has lupus, but they have like a malar rash and some joint pain, and that's really it. And then we have the sort of man-eating lupus where no matter what you throw at them, nothing really seems to get better. And so, you know, to think that they have the same risks and that their disease is moving in the same sort of way, I think is a little unfair. And I think that maybe explains why there are some varying rates of how prevalent PCP is in this population. Most of the retrospective studies show very, very small percentages, so like 1% or less. There was one that was about 5%. But then if you think back to that meta-analysis I mentioned earlier, that was 76,000 patients and only 121 cases, it just makes it really hard to justify prophylaxis sort of universally in this patient population. And if you use those numbers and you talk about the number needed to treat, you know, we said the number needed to harm was 32 for GPA, the number needed to treat is 32, but it rises to about 110 for lupus. And I would argue too, you know, that number needed to harm might actually be even lower in the lupus population, as we talked about Bactrim having specific interactions with lupus. And so again, these are just things that come in to weigh your clinical decision of whether or not to prophylax somebody. So for lupus, I probably would not universally prophylax for PCP. I think you do have to consider the individual risk factors. Again, lymphopenia, I think it's fine to consider the medications they're on. For example, in our consult service, we had somebody who had lupus, developed lupus pneumonitis, and then developed mesenteric vasculitis. And so, you know, she's getting high-dose steroids, she has underlying lung disease, she's going to get Cytoxan. And so one of my colleagues put her on Dapsone prophylaxis, and she had some lymphopenia as well. And I think that was completely appropriate, right? That she made a medical decision weighing risks and benefits, and that seemed to work. And hopefully it will keep this lady from getting a terrible side effect. But, you know, I do think that trying to have a universal statement is just not really going to work. And so we need to sort of weigh the risk of the medication versus the benefit that we would get. And just remember that there is not as much evidence to support that other agents besides Bactrim are equally efficacious in our patient population. And so again, I think that changes that number needed to treat and would actually bump that up higher if you're using agents besides Bactrim. So, inflammatory myopathy. The PCP rate is certainly more common than it is in lupus, but still less common than GPA. The absolute numbers here are just very, very small. There are really only 2 large cohorts to talk about. One was a study by Marie and colleagues, and they looked at 279 patients with dermatomyositis and polymyositis, and they actually looked at all infections. And so they found that about 40% of their population developed a serious infection, but most of them were pyogenic and not opportunistic. So as excited as we get about Bactrim, we have to remember that our medications cause a lot more common problems than they do sort of these rare things like PCP. So they couldn't pull anything off the data just because they only had 3 patients, but they found all cause infections, so pyogenic or opportunistic, there were certain increased risks, and it's going to sound very familiar: lymphopenia, concurrent steroid use, underlying lung disease, and interestingly, respiratory muscle weakness. So these are things to think about in our myositis patients that may lead you to do prophylaxis. I will say too here is that a couple of these cases actually happened before any immunosuppression was given. So we like to think that this is all of our own doing, that we cause this in our patients, but sometimes, again, I think the underlying disease plays a really big role. The second cohort actually included the other 279, and there were about 40 cases per 688. If you calculate that out, the number needed to treat fell around 73. Again, number needed to harm for Bactrim was about 32, so still not as good as GPA, but better than, say, like a lupus. So I would not routinely use prophylaxis in this patient population, but again, I would use that art of medicine and consider the individual risk factors for this patient. Rheumatoid arthritis. PCP is the most common opportunistic infection in this population. Sounds easy enough. We prophylax everybody, right? So I would say no, because it's incredibly rare. There are several meta-analyses that look at rheumatoid arthritis trials. One that looked at 30,000 RA patients and found that only 8 cases of PCP. So that makes, when we talk about those rates per 10,000, and that's 0.051 per 10,000 versus GPA that's like 89 per 10,000. And interestingly, they looked specifically at biologics versus non-biologic therapy, and there was no difference in the rate of PCP. There has been, in general, that seems to be the rate is very low, less than 1%. With one exception, there's one trial out of Japan that showed a slightly higher rate. But again, I think this is when how you make that diagnosis, whether it's colonization or a true infection, comes into play. I will caveat this with one slight thing, is that RA trials are not necessarily looking at severe disease, right? They're looking at inflammatory arthritis, and we treat that differently than we treat like a RA vasculitis or a pachymeningitis. And so there may be times that it's appropriate to do that, but also just to put in perspective, number needed to treat here is 10,099, or excuse me, 1,099, so significantly higher than the number needed to harm. And then just to sort of finish up, I'm going to talk just briefly about these diseases. So PAN, certainly there are several case reports and case series that show that PAN is present, or that PCP can happen in PAN. The rates are very mixed, and so it may be appropriate in times to prophylax. The number needed to treat is around 110, but we see so much less PAN now that I wonder if we looked at it now, if that would actually be a fair number needed to treat. Scleroderma we've touched on a few times, that the rates are still pretty low despite the fact we give medications like Septoxin, despite the fact they have underlying lung disease. So, in general, I would say you shouldn't prophylax scleroderma, but there may be cases where it's warranted. And then lastly, we've talked about, or I guess second to last, we talked about GCA as well, that the rates for PCP are just very low in this population. I actually went back and looked at the GIACTA trials to see if I could see if, number one, they had any prophylaxis, and number two, if there were any cases. I looked through the whole protocol and did not see any prophylactic antibiotics given. And then they don't actually report out PCP, but in general, the opportunistic infection rate was very low. So I think that would signal that this isn't really an issue. Lastly, if you think about all the other diseases we have, adult onset stills, other vasculitides, in general, there's 1 or 2 case reports of all of those, like one of Takayasu's. And so there's just not enough data to say either way. Again, I would probably apply a lot of the similar things that we have talked about to those patients, but in terms of broad strokes, either one way or the other, I don't think we can do that. So it's complicated. I know you came here hoping to have a very set plan of what to do, but I hope instead that I gave you the tools to do this. So I thought Venn diagrams were actually the best way to showcase this, because I think it really highlights those shades of gray and allows us to sort of flex our muscles with our art of medicine, right? Because yes, in general, I'm going to prophylax patients who have GPA. But, you know, you could see where the green and the red overlap. There may be a case where I don't prophylax somebody with GPA, like maybe they have renal limited disease and they have a sulfa allergy, and, you know, they're already dangerously anemic, so I don't want to do dapsone, and I decide, hey, you know what, the risk is probably low, they're not lymphopenic, maybe this is a time that I don't prophylax, right? But then you can see that there would be times that you would prophylax, maybe an RA or a scleroderma, or maybe you would not prophylax a lupus patient, but then the next time you would. So I know it is complicated, but I hope that this talk gave you some of the tools to be able to set the stage for us, to be able to maximize benefit for our patients while decreasing harm as we move forward, trying to make the best decision we can for prophylaxing our connective tissue disease patients. And this is just a few of the references I used. If you have any questions, I certainly can send you the references. And that is all I've got.
All right, Dr. Wolfe, thanks so much. That was great. We do have several questions. I will get started with, there are several about what you think about why GPA patients have particularly high risk. You know, is it something to do with lung disease, or any thoughts on that?
Yeah, so the short answer is no, we don't know why. But I do think it has to do with their underlying pathophysiology. There is a lot of thought that PCP actually needs some of the inflammation to be able to take hold in the lungs. And this is actually, ironically, with all of this, we actually use prednisone to treat PCP, right? You know, you check the ABG to determine if they need prednisone or not. And so the thought is that inflammation is what sort of sets up the infection, and then we give prednisone to treat it because it decreases the inflammation. So I suspect that it has to do with the underlying pathophysiology of the disease and what is going on in the lung, and I think that that's why underlying lung disease does seem to increase the risk as well, or be a contributing factor. So I think it probably has to do with underlying pathophysiology, but in terms of a definitive answer, much like everything in rheumatology, the jury's still out on that one.
Thank you, Rachel. That was terrific. We also have had several questions around using PCP prophylaxis in JAK-STAT inhibitors, such as tofacitinib, or in IL-6 inhibitors, tocilizumab. Any recommendation there?
Again, so I think it kind of depends on the underlying disease that you're using that to treat. You know, it's a complex, right? I think as we kind of discussed, there are a lot of factors that go into the development. And so I think that universally saying that with like a Xeljanz or a tocilizumab that you need to prophylax, I think that oversimplifies it. You know, in general, I think we use Xeljanz to treat mostly like inflammatory arthritis or psoriasis, those types of things. And so I'd probably say in those patient populations, generally the risk outweighs the benefit. But certainly, I think it would be interesting, say, with like tocilizumab right now, as we're using it to treat GCA, does that actually change those GCA numbers? So I think that if anything that came out of this is that I actually have many more questions than I had answers going into. And so I think that we have a lot of opportunity to pull data, even from studies that have already been done, to see if we can help better answer this question and give us more tools to make these decisions.
That's terrific. I actually had a separate question. You know, mycophenolate has its own pneumocystis, anti-pneumocystis activity, and you may have mentioned this or not, but I wonder if that impacted the lupus data at all.
Yeah, so I think it definitely played potentially a role in that. I will say that a lot of the lupus data is from, I think, further back in time before we used as much CellCept. And so, you know, we might find that the rate is actually even lower, right, than what we thought. But yeah, I mean, certainly there are still case series of mycophenolate, like people who are on mycophenolate that develop PCP. But in terms of causality, we really don't have any definitive cause. And I think if anything, if it's a little helpful, then, you know, it would argue that we need less PCP prophylaxis in that population.
I think we might have time for one more. Do you routinely check the CD4 count if you're on the fence about whether to prophylax someone?
I generally don't, because I'm not sure what to do with it. You know, and a very wise doctor once told me never order a lab unless you know what to do with it. And every time I break that rule, I regret it. But I do think that they're probably, it could be a useful diagnostic tool if you really were on the fence and you really couldn't make a decision, you know, but I'm not sure that if it was 250 and I still was really concerned about this patient, like they had leukopenia, they were older, they had underlying lung disease, and they had GPA, or we'll make it less clear cut, lupus, you know, and I was giving them like Cytoxan and steroids, you know, like, are you really, like, even if it comes back at 300, is that going to make you feel completely safe not doing it? So I probably would say it would be best to use your clinical judgment and kind of your that gut instinct, right? Like that's all your medical decision making is what you get when you have a gut feeling. And so I would argue that if your gut feeling is to prophylax, you should go with that and not rely on a marker that we don't really know how to interpret.
With that, we're pretty much out of time. I'd like to thank Dr. Wolfe for her time and giving us this very interesting lecture, and my co-moderator, Dr. Fantis, for helping amalgamate the questions. I do want to remind everyone that there will be a survey particular to this lecture, and that yesterday a general survey was sent out to all registrants that really asks about the overview and the overall effectiveness of the Viral Collaborative. So please take some time to fill out the survey related to this lecture and the survey related to the lecture series. Thanks so much, and we'll see you for the last webinar this coming Friday.
Thank you so much.
Bye-bye.